Hello, this is a local anaesthetic presentation and I'm going to do it on behalf of the College of Podiatry, hence it's College of Podiatry badged. It's going to be an ankle block technique presentation with a little bit of theory. So it'll be some PowerPoint slides to start with and then a couple of videos at the end. One will be a short neuroanatomy overview and then a short video of a patient that had an ankle block prior to bunion surgery. So I've been asked to do this by the College of Podiatry. They actually want me to do it with a video, but do you know what? I think at the moment with the COVID-19 lockdown, I've got COVID hair and it's much nicer doing it, I think, without the video. But we'll see. Maybe I'll do some more with the video if I can get talked into it. A face that would startle a police force, unfortunately. So let's talk. The video is aimed at UK podiatrists, so therefore we are, as a professional group, still wedded to the dental syringe and 3% Scandiness mipivacaine plane, and that's absolutely fine and dandy for digital blocks, and it does an okay job at ankle blocks, but it's not really the height of technology when it comes to regional blocks. So I would recommend looking at some other kit. And the Luer syringe really is the go-to in anaesthesia. We've got both Luer slip and Luer lock syringes where the needle can either press fit or screw into the syringe itself. And that would be the standard and has been for years and decades. And that's the picture on the left. On the right, you'll see a yellow syringe, and this is known as the NR Fit syringe. This is coming over the last year or two. And it's come about from some accidental intravascular injections of local anaesthetic. If you think about your anaesthetist who's giving a patient general anaesthesia, typically with propofol or some other induction agent in the back of a hand via a cannula, they'll often have a range of other injectables that they'll give, maybe some fentanyl for pain, maybe an antiemetic such as a densitron to stop patients being sick. And it's been all too easy to accidentally give a local anaesthetic shot into the back of the cannula because it's been on there on the tray. So over recent years, there's been a move to having a separate injection system for local anaesthetics, which is incompatible with the cannula, and that's the NR Fit. So that's just a little bit of background information there. Needles, of course, once you start to play about with syringes, you can also then play about with different gauges of needles. Purcell's law is a law of physics that gives the pressure drop for an incompressible Newtonian fluid that flows through a cylindrical pipe of constant cross-sectional diameter when it does so in laminar flow. This has been related within the medical world to blood circulation, microcirculation particularly, but also hypodermic syringes. Now, what that means for us is a wider gauge, a wider diameter needle will be easier to inject through, will require less pressure. So it won't come out as fast at the other end, which will be potentially an easier injection for us to give and less painful for the patient. You've got to balance that, of course, by the fact that a smaller needle is likely to be less painful. So round about in the middle, a 23 gauge needle is really my recommendation as a go-to. Quick couple of slides, and again, this is aimed at a UK podiatry audience. So in UK in 2005, the MHRA published a consultation about proposing to extend the range of medicines that could be sold, supplied or administered by podiatrists, and that led to a statutory instrument at the end of 2006 that gave us access actually to a range of drugs, but particularly two new local anaesthetics. And those were levobupivacaine hydrochloride and ropivacaine hydrochloride. Brand names for those would be Kyrocaine and Narapin. And they're in many ways better local anaesthetics because you've got a wider therapeutic window. The margin of error is larger, and it's a safer drug, and particularly they are less cardiotoxic, so you can use more, they're safer, they last longer, so all round they're a better drug. Kyrocaine probably would be my go-to drug, comes as two percentages, 0.25 and 0.5%. Picture on the left is me doing an injection for tarsal tunnel syndrome. The 0.25 normally comes in little green ampules, and the 0.5 is yellow. Central picture is of me actually doing a portopedist block for tarsal tunnel syndrome, and then the picture on the right is Narapin, which is the brand name for ropivacaine. And these are, they're just better local anaesthetic drugs. You really won't find anaesthetists, and they're the people I measure myself against, using Marcaine very commonly now. Other drugs are available, of course. My favourite joke coming up, bamboo cane and Michael Caine. It doesn't get any funnier than that. Okay, let's just have a word or two about dosages if we're thinking about using different drugs. So maximum safe dose refers to the total amount of drug that can be administered for a therapeutic effect with a minimum risk of an adverse effect. Now, it doesn't mean that if you're within an MSD that everything will be tickety-boo, and it doesn't mean that if you break an MSD the patient will have an adverse event and be poorly. Drug manufacturers provide guidelines, though, on the appropriate dosages based on maximum dosage by body weight that can be given to a patient. And the MSD per body weight for levobupivacaine and bupivacaine is 2 milligrams per kilogram. For lignocaine it is 3, although that will vary a little bit from country to country. And for mepivacaine it would be 6. And again, there's some difference in recommendation from country to country, but let's stick with 6. So the amount of drug that a patient can receive in a 24-hour period, I could talk about that all day as well. It's not really as black and white as that, but that's what we like to say in podiatry land. Can be calculated by the sum. Patient weight in kilograms times the drug MSD that's been given by the manufacturer would give a maximum safe dose in milligrams. So if we stick with 70 as the upper ideal body weight in kilograms times 2 for levobupivacaine, that would give us 140 milligrams as a maximum dose. Volume then. So I've said carbocaine comes in 2 different percentages. So clearly, if we've got a 0.25 and a 0.5% solution, we can't give the same amount of volume to stick within that MSD. So we can calculate that using this sum. The unknown volume of a drug times the drug percentage times 10 equates to the maximum safe dose in milligrams that we've just worked out. It's a 2-step method of working it out, but it's my preference. So for levobupivacaine, the MSD is 70 times 2 for somebody, your typical adult, or upper ideal body weight. So our unknown volume times 0.5%, we're using a 0.5% solution here for the sum, times 10 equals 140, and if you move that round, it gives you 28 mils. So that's a 2-step way of working out MSDs. The alternative method is to work it out with a single-step method, if that's your preference, which would be body weight in kilograms times the MSD of the drug, milligrams per kilogram, divided by the concentration of the solution in milligrams per milliliter. So the maximum safe volume for 0.5% levobupivacaine would be 70 times 2 divided by 5 for a 0.5% solution, and that would again give you the 28 mils of solution. I'll just put the one in for mepivacaine. 3% mepivacaine would work out at 14 mils for your typical adult patient. Let's talk techniques then. We'll concentrate on the tibial block, but we'll talk about some of the other techniques as well. And I suppose we've always got to think about the what I like to refer to as the 2-up bags of smoke technique, which is saying let's just do a direct infiltration to a plantar lesion. Old picture of mine, you can see the almost see-through gloves that I'm wearing there. And I did this prior to curating that verruca from the plantar aspect of the foot. Now, I will do this from time to time, but it wouldn't be my recommendation for a go-to technique. What I will do, and this is a screenshot taken from my YouTube channel, is I'll do what I call a cheat technique, which is coming from the side of the foot where the initial scratch and sting of the injection isn't quite so bad, to do a plantar infiltration but coming from the side. And that's really quite an acceptable technique. You can see here that I'm using some local anaesthetic with adrenaline to blanch the tissues. This is prior to verruca needling. But of course, if we want to think about doing an ankle block per se, then we need to block one or all of the 5 nerves that supply the ankle. And they are saphenous, superficial and deep perineal, sural, and the posterior tibial. So those are the 5 nerves that we should remember in terms of our gross neuroanatomy. And we need to think about not only where the dermatome is, but also where the cutaneous distribution of those nerves is as well. So here's the cutaneous distribution. I'd probably take issue with in orange at the bottom where the tibial nerve is being labelled. I think that's really better, the medial calcaneal nerve, but it's quite a nice graphic. The medial and lateral plantar nerve supply the plantar aspect to the foot, and they split the 4th toe, and the saphenous and the sural will innervate just the sides of the foot, and of course the innervation will be somewhat variable from patient to patient. On the top of the foot, we all remember from first year anatomy that the deep perineal nerve, sometimes known as the deep fibular nerve, innervates the cleft of the first toe. And again, the saphenous and sural will do the medial and lateral aspects of the foot. Tibial nerve then, and it's going to come around the back of the medial malleolus. Picture taken from Primal Pictures all the way back from 1999, lovely piece of software that we used to use a lot. It's a branch of the sciatic nerve, supplies the plantar aspect of the foot via the medial and the lateral plantar nerves and the calcaneal branches we've just mentioned, and is located posterior lateral to the tibial artery. So that's from the Primal Pictures CD, as was, sadly no longer produced. Here's another shot from Primal on the left, the leg just rotated around a little more, and you can actually see as the tibial nerve comes down, the first branch that comes off is actually the calcaneal branch. In this graphic, it's actually slightly inaccurate in that the branch pierces the flexor retinaculum and becomes cutaneous really quite quickly. In this picture, you'd think it remains quite deep. Picture on the right is taken from one of the cadaver courses that I run, and you can see that the nerve is grasped with my right hand between my thumb and index finger and splits into 4, and those branches from medial to lateral in the view are the medial and lateral plantar nerve. First branch of the lateral plantar nerve, which is Baxter's nerve, also known as the inferior calcaneal nerve, and the medial calcaneal nerve. So here's a patient, and we're going to mark in the posterior tibial artery. So that would be 1, and this roughly equates to where the medial and the lateral plantar nerve would be. Of course, that's a 2D picture, and you've got to think about those nerves in 3D, and the medial calcaneal nerve. If you've got a higher volume ankle, it can be quite useful to mark up the tip of the medial malleolus, mark up the corner of the heel, take a bisection, take a line between the two and bisect that, and the neurovascular structures are always going to be in the top half of that bisection. So if you're new to doing ankle blocks and you want to mark this up, this is really quite useful. And if you've got that higher volume or that very big patient, that very big ankle, this really helps. Of course, most times you're going to be able to go straight to the artery. You might go straight to Doppler in the artery, but this is just one of those tips that I find useful. The needle, you're going to want to go just inferior to the tibial artery pulse and direct that needle just below that, because that nerve is posterior lateral to the artery. So thinking in 3D, that's where you want the tip of the needle to be. So pop the needle underneath the skin, advance slowly. If paresthesia is obtained, if you're just touching the nerve, which you don't want to do, but if you do, withdraw the needle just slightly and you inject 3 to 5 mils of local anaesthesia. For me, with 3 to 5 mils of Kyrocaine or Narapin. And have I mentioned there? No, I've not. You would aspirate, absolutely aspirate, but I'll come on to that in the next slide actually. So look at what you can achieve with aspirating with a Lewis syringe, and I just think I've got much better confidence that if you actually within a vessel when you aspirate, that you're actually going to get some blood flow back into the syringe with a Lewis syringe. This is an old pick of mine, and you can see in the top that there are some dental syringes knocking about. I think they've probably been thrown away now. Deep perineal nerve then, top of the foot. You want to locate the dorsalis pedis artery, insert the needle lateral to that and go deep to the deep fascia. That's why it's called the deep perineal nerve. Aspirate and inject 1 to 2 mils of anaesthetic. On the top of the foot, looking at the superficial perineal nerve. This is a picture from McKinn's Colour Atlas of Foot and Ankle Anatomy, which is an excellent book. And I'm on this particular picture, number 1, 2 and 4 are labelled up as the medial and lateral branch of the superficial perineal nerve, and 4 is the sural nerve. So 1 and 2, the superficial perineal nerve has 2 branches. Sometimes when it pierces the lower third of the leg, it comes out as 1 branch and then splits. In this particular case, it's in 2, and the sural nerve as number 4 is obviously supplying the lateral aspect of the foot. So to block that, I would typically start 1 finger breadth in from the lateral malleolus, and I'd make a mark, insert the needle at that point and raise a subcutaneous injection of local anaesthesia, and advance the needle medially, injecting as I go to create a sausage of anaesthesia sub-Q. And it is sub-Q, subcutaneous. If you go too deep and pierce the deep fascia, you'll just inject the ankle joint and you'll miss the superficial perineal nerve. Sometimes you'll need to do this with 2 passes, and I'll inject 3 to 5 mils of local anaesthesia. Sural nerve, also subcutaneous, and it's quite close to the lesser saphenous vein. Again, if you were to take a bisection of the tip of the lateral malleolus and the tip of the heel, it is within the upper half of that bisection. And then medially, the saphenous vein is on the lateral aspect of the nerve, and it's the only nerve in the foot that doesn't come directly off the sciatic. The saphenous nerve comes off the femoral nerve. It's blocked with a subcutaneous infiltration on the dorsal foot or medial ankle, and I would typically inject 1 to 2 mils of local anaesthetic, again with aspiration, because you're very close to a vein. You don't want that local anaesthetic to go straight into a vein, and then we'll go straight into the systemic circulation. Bit of a run through there. Further information in a book that Stuart and I did back in 2010. I think that's quite a good little reference for podiatrists. Really good reference on the internet is the New York School of Regional Anaesthesia. They have excellent videos and tutorials. There'll obviously be some difference in technique, how clinician A from clinician B will do it, but that's a particularly good website. And I've got a few more videos on my YouTube channel if you can be tempted. Okay, so coming up now is going to be a quick run through on neuroanatomy on a real foot, and then an actual technique on a patient.
Okay, we're going to run through the 5 nerves of the foot. So the first one we'll do is the tibial nerve. Neuroanatomy will be mark the tip of the medial malleolus. If you take a line of the tip on the heel, let's just bring that into shot a little bit, that's better. You can take a line between the two, and the tibial nerve is going to come down at about this level here. Your marker will be posterior tibial artery, which is going to be in this area here. The nerve is going to be posterior lateral, so if you go on that line of bisection, that would be your entry point, and your needle would come in and aim to come behind the artery posterior lateral. While with this area of the foot, next point would be saphenous. You can't really see it on this skinny foot, but the saphenous vein is going to be coming down round about here, and the saphenous nerve is going to be medial to the saphenous vein. We will swap feet now. We'll put another foot up. Haha, even better. Let's just put that foot down. This is kind of nice. Here's a nice skinny foot. So now you can actually see on this foot lateral branch of the superficial perineal nerve. It's coming down there. So that's going to be a really nice, easy one to catch. What I like to do with these is come in 1 finger breadth in. Let me just come down a little bit. 1 finger breadth in from the lateral malleolus. And I'll make a mark. And then I'll come in from about there. And I'll raise a sausage of anaesthesia across the top of the foot, sub-Q, superficial, across that area. So there you can see the first branch and the medial branch is there. Sural, let's just invert that foot. The sural nerve is going to be coming around in that area there. And again, between a bisection of the lateral malleolus this time and the tip of the heel, it's in this half of the bisection. The one we're missing is the deep perineal nerve. Landmark for that is going to be dorsalis pedis artery. So palpate, use a Doppler if you can't find it. I've just found it there. There's the artery, and the nerve is typically, not always, lateral to the artery. So you're going to come in at that point there, and it's deep, deep to bone, deep to the deep fascia. We're just going to feel, there's the artery there. Coming down at that point there. We're going to come in below that. She's already had skin prep, by the way. Saphenous, there's the saphenous vein coming in. We're going to go medial to that. On the top of the foot, this is the one that actually innervates the joint itself. And there's the dorsalis pedis artery. And the deep perineal nerve is lateral to that. And the last one we'll need to do is the superficial perineal, which in skinny patients like Di, you can normally see, not quite see it there, that's going to come down on the front of the foot. So we're going to do a wall of anaesthesia on the top of the foot there. So those are the 4 nerves for that. The one we don't need to do is the sural because we're on the big toe. We'll do the saphenous first. So there's the saphenous vein, saphenous nerve just medial 2. Di, little scratch, 3, 2, 1, scratch. And we aspirate to that point. And little sting, sorry Di, little sting on the top, just a mil or 2 off. That's going to do that one nicely. We'll come on the top. We'll do dorsalis pedis, lateral, which is deep perineal nerve, down to bone, scratch. Sorry, chucky egg. Down to bone, we stay deep because it's the deep perineal nerve. Don't need to aspirate at this point because you're right by an artery. That anaesthetic is going to go distally. Sometimes it's a little difficult injection to give because it's very tight underneath that fascia. Needing to be a bit persuasive there. Sorry.
You did so well not to swear on the live camera then, Di.
Thank you.
So impressed with that.
Scratch.
I felt that with you.
Scratch. This one stings a little bit, it's just underneath the skin. So I normally do 2 passes at the front of the ankle. And that's going to do dorsal medial hallux. Well done you. And then the last one, I'll rotate the foot round again. Tibial, there's our artery. We're going to come posterior lateral with the needle, scratch, 3, 2, 1. And we're going to aim to become behind the artery. Very, very gently advancing the needle, not looking for needle paresthesia. Aspirate, nothing in there. Di, little sting as that goes in. Do you feel that?
That's okay.
I normally put about 5 of the mix in there. And then that's going to take about 20 minutes to go. So Scott and I are going to go outside, have a coffee, and we're going to come back when the patient's numb. Thank you, sir. You were awesome.